Thank you. Thank you for some wonderful talks. Can we start out, Dr. Ulrich? You showed a map there of taxation in states for sugar-sweetened beverages. Can you tell me what the experience is with taxation for sugar-sweetened beverages, both in the United States and in several of the other countries that have started?
Yeah, that's an excellent question. So there's good news and bad news. So the good news at first is that people are thinking about it at the federal level, the state level, the local level, and that there are now data that show how efficacious those sugar-sweetened beverage taxes can be. They come from Mexico. More than 6,000 households were looked at, and they showed that through these taxation, you basically changed the patterns of consumption within households, and especially among poorer communities. And I think that's exactly where we want to go. Now, the bad news is that there is beginning to come enormous pushback, similar to what we had with the tobacco industry. There are large-scale lobbying efforts, multi-million lobbying efforts in Philadelphia, in California. They just came up with a agreement with California to have no additional taxes in exchange for not pushing for a limit in ever-changing taxation for any food items again. And so we need to be very mindful that we're starting to get a lot of pushback here, and unfortunately it's also very politically charged. It's coming back to saying personal freedom and why should we tax any kind of foods. And one solution may be to do what the Europeans are doing. They are having implemented these a little bit later, but they use a more tiered approach. So it really means like you pay higher taxes depending on how much sugar is in the beverage. And in France, they go by gram even. And that gives us perhaps a way to work with the beverage association, the beverage industry, to just reduce sugar intake slowly but surely and wean people from so much sugar in our diet. So that may be a bit of a positive outlook here.
I see. Now, Ernie, you're old enough that you went into prevention when it wasn't sexy.
Absolutely.
Tell me this. What are we going to do to create a culture of prevention?
Well, I think the first is to acknowledge the opportunity and to try to prioritize that as a part of a national strategy. I am an advocate of our nation moving toward the development and implementation of a national cancer control plan. I just finished an effort with an international organization that assayed the status of cancer control planning across the globe, and learned that as a part of that many countries have moved in this direction. Most of them in terms of planning, not yet implementation, but I think that's a very encouraging sign. Here in the U.S., you may know that we have some 58 or so different plans, one for each state, as well as several of the Native American tribes. To my mind, when you have 58 plans, you probably have no functional plan, thinking at least as a nation. So I think that effort, creating a blueprint, is first of all extremely important. Second, commissioning the CDC consistently across time as the champion of implementation of that effort, particularly to reach underserved communities, just as Neely pointed out, is extremely important. Finally, I think that the NCI has invested over the last 30, 40 years, maybe even 50, 60 years at this point, in the NCI Designated Cancer Centers program. So we have 70 champions across the nation, and commissioning them a bit more to be active in this space of public policy, public professional education, as well as delivery of services to underserved communities, I think will be a very important part of fostering prevention in the way it should be delivered. There have already been pilot efforts, as you're aware, Otis, in several communities where the communities themselves have organized around a particular goal. I'm thinking in particular of getting colorectal cancer screening. And to my astonishment, drawing upon all sectors, educating the public, establishing policies that bring together a community, both individuals living in it, but also importantly, insurers as well as the healthcare enterprise, able to eliminate colorectal cancer disparities in a shorter period of 7 years. That suggests a real model that could be implemented more broadly, and I think should be.
Yeah, I should point out there are states in the United States that have had a 60% decline in colorectal cancer deaths over the last 30 years, and there are states that have had a 15% decline. The states with a 15% decline tend to be in the Old South, and the states with the 60% decline tend to be in the Northeast. Now, Dr. Offit, cancer screening has been contentious. There are good screens and bad screens when we're talking about for cancer itself. Tell me a little bit about genetic screening. Should we all be going out and within the medical infrastructure, not at a New York socialite party, should we all be getting genetically screened for BRCA or other mutations?
So it's really one of the pressing questions. Our societies, our professional groups say, no, we're not ready yet. We don't fulfill the CDC, Marin-Curie's, and other criteria for screening. And yet the commercial companies have charged out and done it. So where do we stand on this? So I've told you a little bit about our pilot studies, and in the population that we're looking at, where we have very simple genetic screening with very simple tests and a risk that's an order of magnitude above, this is in the Ashkenazi population, we're finding that about 40% of the individuals would like to get the results from their physicians, their healthcare providers. But then when we ask the providers, half of them say, can't handle this, all right? So this is early going in this study, but the first message is we, as the profession, are not up to the task, and so then we're leaving this by default to this recreational application of testing. And I've just showed you that most of our interventions, they're not medical, they're surgical interventions. And for many of you out there thinking of screening, we're like the general public. You know, you need to have a lot of information to feel confident to go forward and get testing. And most folks will not do this without some medical support. The other side of the screening, which has been somewhat surprising, is in the cancer centers, where we're doing the germline testing almost as a sidelight of screening for the tumors for targeted therapy. This is an extraordinary teachable moment, because now we have patients under medical care that we can speak to intervene in their family members. And I showed you that high proportion in advanced cancer patients. But again, we need the oncology community to then embrace genetic counseling. That means taking time out from a busy management of an advanced cancer patient to talk to family members. So on both of these axes, I think that the answer is yes, we should be doing this, but we need, as a group, as a profession, as a society, an academy, to think seriously about bringing our healthcare professionals into the genomic revolution, as it were, or we leave it by default to the for-profit sector.
Dr. Lowy, I've heard politicians, including oncologic politicians, talk about the elimination of cervical cancer, the eradication of cervical cancer, all of which have specific meanings to us in epidemiology, by the way. I noticed you very carefully talked about the control of cervical cancer. You want to expound on that a little bit?
Our current level of cervical cancer in the United States is about 7 cases per 100,000. Back in 1950, we were about 40 cases. So there's been a dramatic decrease as a result of cervical cancer screening. The World Health Organization has proposed as a elimination goal of 4 cases per 100,000. So you can see that we would need less than a 2-fold decrease in our incidence to achieve that. My own feeling is that we should be striving to do this regardless of how you define it, whether you call it elimination or control or eradication. In the short term, we really need to provide better access for women who are underscreened, so that they can be so that they can receive high quality screening. And I think that research currently going on will, in the near future, lead to self-sampling for women, and I think that will actually have a very big impact. In the developing world, it's crystal clear that we should walk before we run, and we should figure out how to bend the curve and control cervical cancer before we start seriously discussing how to eliminate it.
Now, when we talk about health disparities, I'm going to ask about other cancers in a little bit, but cervical cancer is one of those cancers where there are huge disparities, correct? Now, talk about tackling those disparities in the United States versus tackling those disparities in, say, sub-Saharan Africa. Should our approach be different?
Well, certainly we have a mandate to, because we have the benefit of congressionally funded appropriations that comes from the American taxpayer. We have a mandate to try to provide the research that can lead to high quality health care for everyone. And therefore, as Ernie was pointing out, for example, the NCI designated cancer centers, one locus for trying to improve or reduce that disparity gap. When things work well, however, you also can try to have an impact on global cancer, where the increase in the amount of cancer is projected to be for the foreseeable future much more than in the industrialized areas. And I suppose fortuitously you could say it's fortunate with cervical cancer that both vaccination and screening are areas where you can do research that can be relevant both for the developing world as well as for the industrialized world.
The Affordable Care Act removed the co-pays for preventive interventions. Any of you want to talk about how that has helped? And also, I don't know what the state, I know the current administration is making some changes to the Affordable Care Act. Are we going to lose that waiver of copay? And as a result of losing that waiver of copay, are we going to have a rebound in terms of disease? This is probably a question for the three of you guys and not for Dr. Lowy.
So I reviewed this for an ASCO symposium a couple of years ago, and clearly the Affordable Care Act has made a significant impact, particularly in cancer screening. I think we reviewed 3 or 4 studies back at that time, and that was just a year ago or so, where removing that financial barrier and increasing the public awareness and visibility as well as professional practice of that has had a very significant impact. In terms of the current political environment and what might lie ahead for that, I'm uncertain. However, another very important aspect, I think, of the benefit of that in the cancer world was it took us from a framework in which, frankly, many practitioners were offering something like colon cancer screening with a screening intention but with a diagnostic coding. Those days were changed as a result of the Affordable Care Act, and there was actually the ability to be honest about the clinical services that were being provided, all with the intention of helping people. So I think the Affordable Care Act has been a very important step forward for elevating prevention across the nation in cancer specifically, and it would be a huge step back to see that removed.
Would you agree that the Affordable Care Act and things like the CDC-funded breast and cervical cancer screening program have actually reduced disparities?
I think they have demonstrably and importantly. However, even as good as they are, they don't reach nearly the population that's required. In Texas, for example, we have rates of uninsured population on the order of 15 to 20%, and in some subsectors of the population, particularly in Texas, Hispanic Americans, those rates can rise as high as 30, 35%. Those folks are not addressed by the Affordable Care Act, and that's why we need to be much more proactive and progressive. I took notes in Dr. Zhao's presentation. I love the quote from Benjamin Mays. I see it every day. I mean, complacency, doing too little, not acting on the information, living below our capacity. That's what needs to change.
Yeah, I should point out that we've already seen that states that have expanded the Affordable Care Act or expanded Medicaid under the Affordable Care Act seem to have better outcomes than states that have not, and we're increasing state-by-state disparities by having some states that have not expanded Medicaid and some that have. Let's get back to a little bit more to science. Dr. Offit, Dr. Ulrich, how do you calculate attributable fractions when it comes to cause? We showed all these percentages for 33% of all cancers are caused by tobacco, for example. How do you calculate that?
Well, maybe I'll start. So there has been, of course, a very detailed methodology developed that takes into account both the relative risk that is changing for each exposure, as well as the prevalence of the exposure in the population. And then it calculates it for each different type of cancer. There are some that are related to obesity or diet, some that are not. And so it's a very complex mechanism, but it's now become very robust. And I think over the past decades, we are very solid in our knowledge of where the attributable fractions are. There's a little bit of debate about how much genetics contributes, and some of that has to do with the fact that we also have gene-environment interactions. And that, for example, going back to that picture I showed about the Japanese, if you looked carefully, you saw that the colon cancer actually exceeded the rates of the Caucasians after the second generation. And we believe there's actually some susceptibility genes among the Japanese that with the appropriate exposures, they can even have a higher risk.
Okay, Ken, I'm going to give you a softball.
Yeah, I'll follow up with this too. Yeah, and I'll take your softball. But the example, that really points to the G by E is lung cancer. So you notice that was up there on the twin studies. And so, well, what's lung cancer doing as a heritable disease, right? Because lung cancer, it's all environmental. Lung cancer didn't exist in Homo sapiens until 1895, we think. The Greeks didn't see it in autopsy series, right? So well, no, that's the fact. There are no thoracic tumors, right, that were found, and they could look. So how is it then, what's the heritable business there? And yet you see it in the twin studies, you see it in the Utah genealogies, and this is sort of the next generation of what you're referring to, which are the gene by E interactions. So some of us living in New York, wiping that black soot off of our windows, are going to be more susceptible to lung cancer from environmental agents, and there is a susceptibility to environmental agents. We're just beginning to get at this through our GWAS studies. So these aren't the high penetrant BRCA genes, although interestingly, there's some of that in lung cancer we'll show, but most of it is this interaction of the gene with the environment, and that's that attributable fraction. So it's an epidemiologic construct. Which is not so comfortable to geneticists, but it is real. There is this interaction.
Yeah, even I struggle with the concept of risk. The softball is you discovered a BRCA mutation, a specific mutation, and I'm told that people who have that mutation have X% risk of getting breast cancer. Why isn't it 100%?
So this again now, we were covering all the big issues. So we just mentioned G by E, which is what we call gene environment. And now we're talking about G by G. And so there are interactions of modifier genes. We know this in mouse models, and now we're just seeing this in humans. So one of the sort of Gedunken experiments that we did a number of years ago, real experiment, look at all of the folks, the women who have BRCA mutations on the planet Earth, who are 80 and never got cancer, and do a genome-wide association and say, well, what is it that protected them, and what are the modifiers? And there are modifiers, and we will soon in the next few years introduce into clinical availability those modifiers that will take that risk in addition to the underlying background of the high penetrant gene, BRCA, and take it from the 40 to 50 up to the 80 to 90. So there are these G by G, gene-specific modifier effects that we're now just beginning to become aware of.
I'm going to ask Dr. Ulrich to respond to that, but anyone who wants to ask a question, head to the microphone so we can be as expeditious as possible in getting some questions to the audience.
So I just want to mention briefly that even among high-risk families where there's a predisposition to having a lot of cancer, for example, Lynch syndrome, there is really interesting evidence that the environment still plays a role. So somebody did actually go back and followed a family that has a mutation in a mismatch repair gene, which then results in what we now know as colon cancer, Lynch syndrome. And in the original generations, back in the 1910, 20, 30, there was no colon cancer in that family. It was all different types of cancer. It was mostly uterine cancer, or I forgot what else. But anyway, the colon cancer didn't emerge until like 3 generations later. And what that tells us that even in those high-risk families, there was something that changed in the environment, in their exposures, but probably their diet, that made them now express a phenotype that's colon cancer. And I think that's very powerful because it still shows us that, yes, we have even here the potential to prevent.
Well, Ernie mentioned the aspirin, which is a big deal. I mean, in Lynch syndrome, it looks like aspirin cuts the risk by 40%. So think of all the prior epidemiologic studies where we didn't control for aspirin to modify, that risk. So there are exquisite interactions like that.
Dr. Lowy, HPV prevents cervical cancer. There are 5 other cancers that are caused by HPV: head, neck, anal, so forth. Are they prevented by these vaccines?
So the vaccines are approved for preventing the other cancers that are anogenital cancers, anal cancer and vulvar and vaginal. They are not approved for head and neck cancer. But there is evidence that was published earlier this year that people who have been vaccinated, their carriage of oral HPV is down about 88% compared to the people who have not been vaccinated. So there's every reason to believe that it would be effective there. The reason it hasn't been approved there is there's no pre-malignant lesion the way there is in the anogenital area.
Okay. Dr. Ullman, would you introduce yourself and answer your question?
Gil Oman, University of Michigan. So this is a terrific panel and the program. I want to focus on chemo prevention. You just mentioned aspirin, NSAIDs for colon cancer. Tamoxifen was in a slide that Nellie put up. But since the big CARA trial and the big SELECT trial, we sort of got discouraged. You'd think by this time, with all the knowledge about mechanisms, we would have a tremendous effort in academia and in industry to target preventive interventions. What are the prospects?
For the audience, the CARROT trial was a study where we looked at beta-carotene versus placebo in smokers, and we ended up finding a higher risk of lung cancer in people who got the beta-carotene versus the placebo. The SELECT trial used selenium and vitamin E, and I get them confused. Selenium, I believe, was associated with a higher risk of diabetes, and vitamin E with a higher risk of stroke.
But the combination was associated with a higher risk of invasive prostate cancers.
That's right.
And the beta-carotene story, of course, after the clinical trial was done, the basic science done in unusual species that were appropriate showed it was highly carcinogenic.
So I'll take the question. Thank you, Gil. I think the potential for chemo prevention is profound, and I personally feel that it will probably first be realized in high-risk cohorts, which is why I emphasized in my presentation working in germline colorectal cancer cohorts and Ken and his in germline breast settings. I think those are the most appropriate populations in whom to test chemopreventive compounds. We have been disappointed not only by the CARROT trial, but by many other trials where we moved predominantly from observational associations in large populations, many times reproduced across studies, and went directly to their potential to prevent cancer. Now, most of the field is concentrated on a more traditional approach to drug development that incorporates not only observational indications, some of which can be extremely important, as I referenced tamoxifen and breast cancer prevention, but also mechanistic inquiries as well as compelling animal data. And to my mind, the next step in trying to accelerate investment in this field is better understanding those early stages of cancer development from normal to precancer. Understanding that molecular pathogenesis is going to be key to identifying in whom we might be able to treat such a precancerous model, as well as the mechanistic approaches that we might take to be most effective. Fortunately, the field has accelerated because of the work of Doug and others who have built upon infectious causes in particular. And he shared the data both with hepatitis B as well as his work in HPV. Similar sorts of data are available now for the identification and treatment for hepatitis C. So I think there's a lot of work that's going on. Unfortunately, in the mechanistic driven chemo prevention specifically, I feel we don't yet have enough knowledge about the molecular determinants of those very early stages, which is why I advocated for a precancer genome atlas as a very important contribution to that future.
Right.
I'll add just very quickly, for diet, we have the challenge that it's a very complex exposure that has been identified in observational studies as being relevant, and then pulling out one nutrient has not been successful. But we just recently in Utah had a very successful trial with erlotinib and solandac in FAP patients. This is probably one of the top examples of chemoprevention, where we were able, again, in a high-risk cohort, people who get normally hundreds of polyps in their duodenum and their colon, we were able to shrink that down to virtually nothing. And so there's still potential and need for that. Thank you.
Colorful vegetables are still to be encouraged, or consumption thereof?
So, okay, can I say something about vegetables? so there's an interesting question. The vegetable associations used to be a lot stronger in many, many studies than they are today. And one aspect that I learned from my former mentor, John Potter, is also our vegetables have changed, our fruits have changed. They have been bred now for size, storability, and equal basically transport. And what has been bred out of them is anything that's like tasting a little bit bitter. There are a lot of data that show that basically our vegetables today are not the vegetables we used to have. So we may need to think about that aspect, and that's going to be a big challenge again.
You're shaking my world. Yes, ma'am.
Hi, Jen DeVoe, family physician. Also have the great privilege of helping to lead our new NAM interest group in primary care. So you all alluded to the need to have a rational, equitable healthcare system to help deliver all these new innovations and continue the science. Yet many of us have that, but millions of people in our country don't. So I'm wondering what you would recommend the NAM do and the academies related to improving, accelerating, transforming our primary healthcare system and helping ensure that everyone in our country gets access to good primary healthcare and prevention that currently exists, and then what you're talking about in the future.
Dr. Ulrich?
That's a very challenging question. Right now, I'm on the panel from the National Academy for Cancer Control Plan, and I think what we can do in the short term is, for example, for obesity, try to tackle the areas that are policy areas that will benefit also underserved populations that are not directly linked to insurance until we have a different administration, but we can still impact. We should all speak out, as has been mentioned before. I'm coming from a country where we have universal coverage and it makes a big difference. But I think there is a lot we can do outside of tackling insurance at this point as well and trying to improve people's health through that.
One of the reasons why I and my EPI group do calculations on how many people would not die from cancer if everybody had what college-educated people have is, number one, to try to show that we can do something to prevent deaths in cancer. And number two, to try to encourage people to get some excitement about doing those things. I will tell you, and this is a personal view, there are some folks who have yet to be concerned about other people. There are a couple of wonderful young people here from the Naval Academy. I was talking to them about when I was deployed in 2009. I was on a ship that had a sign on it as we left a ship. Anytime we left a ship, we're Americans, we leave no one behind. I came back to Atlanta to Grady Hospital and I walked the halls and I said, we're Americans, we leave a lot of people behind. Okay, we've got to stop leaving people behind. Next question. Dr.
Art Kellerman, Dean of America's Medical School at Uniformed Services University. For Dr. Lowy, I'm the father of a 30-year-old gentleman. You didn't really speak much about the recent expansion of the age range for HPV vaccine. If you were me, would you tie him to a chair tonight? Would you pay out of pocket? How would you handle his now new opportunity to get a vaccine that he was previously ineligible for?
That's why God invented the CDC. The federal regulations are really, I should say the federal recommendations are made by the Advisory Committee on Immunization Practices, which I believe are going to be meeting later this month to make recommendations. What the FDA said is that they think that it is that this is an effective intervention. And clearly, the vaccine can benefit people who are above 26 in terms of protecting them against infection. I think that the key issue is preventing cancer and preventing deaths. And the epidemiology of HPV infection, at least in women, is that most of the cancer-causing infections are thought to occur before the age of 25 or 30. So that although it can be effective, the most appropriate time or the best benefit would be when people are vaccinated before they become sexually active.
Sir, we're going to try to quickly get you in, and then we're going to get the doctors out.
Birch Greggs, Rochester, New York. There seemed to be a general lamentation from the panel on the inability or unwillingness of physicians to really jump on the prevention bandwagon. But physicians, in fact, are driving the wagon when it comes to treating incidentalomas. And there was actually no mention of that, but with the increasing availability of imaging, whole body scanning, this type of thing, this seems to me to be reiterating the issue of PSA screening, mammography, but it is a way of preventing a certain number of cancer deaths, I am sure. Could you comment on what you think ought to be done in terms of how we would structure that? Because I think we're getting a need for guidelines on that.
Anybody? Go ahead.
This is an issue, it's really the question of overdiagnosis. And because cancer frequently is a heterogeneous disease, just because you detect cancer doesn't necessarily mean that that detection is going to enable you to lead a better lifestyle or a longer life. And I think that the problem has really been emphasized for PSA screening with prostate cancer, as you mentioned, because many men who develop prostate cancer are destined to die with prostate cancer. And the real problem for research is to figure out those people who are destined to die from prostate cancer, who have potentially lethal prostate cancer. And that's where we really just need to do more research.
Well, just to follow up on that, I think the genetics is a great help here. And on a more optimistic note, the reimbursement for genetic testing is now part of our medical practice. There has been no genetic discrimination. And these genetic markers, take prostate cancer, for example. The BRCA2 mutation carriers that we will detect in this study, when they develop prostate cancer, every one will be Gleason 7 or 8 or higher. So here we have a genetic marker that changes the whole balance of thinking about PSA detection in this subgroup. And I think the same can be said for a number of our other genetically described syndromes, where this issue of the incidentaloma versus the high posterior probability of finding a true positive weighs very much in favor of screening.
Yeah, I want to say thank you just to the prostate question, just to bring everybody to the same level in 15 seconds. After 20 years of debating prostate cancer screening and treatment, we now know if you take 1,000 men age 50 and screen them over 20 years, you will diagnose 150 with prostate cancer, and you will have 4 who die from prostate cancer. If you have 1,000 men of the same age who do not get screened, you will have 75 diagnosed with prostate cancer, and you will have 5 die of prostate cancer. Those are real numbers from real trials. So genomics may help us to figure out the ones who don't need to be treated and need to be watched and the ones who do need to be treated. But that's a discussion for another panel. Dr. Zhao.
Thank you very much.